Hi everyone, and welcome to week 4 of the rolling teaching program for sickle cell disease. My name is Christopher Dean. I am the pediatric red cell nurse specialist here at UCLH. I'm also the lead nurse for training and education for our red cell network. So week 4's topic will cover pain in sickle cell disease. But before we begin the actual presentation, I will go over some learning objectives. These objectives include that we'd like the candidates to gain more understanding of the cause of the pain, with particular focus on the vaso-occlusive crises. Candidates will be aware of treatment regimens used to control the pain in sickle cell disease on presentation in the hospital, including multiple analgesic routes, and also to understand the difference between acute and chronic pain and the difficulties in treating those. But first of all, let's have a quick talk about what causes the pain. By the way, guys, if you have any questions, please put your hands up or maybe wait to the end. I'm easy either way. So for those of you who attended the previous sessions, we all know that the pain in sickle cell is mainly caused by vaso-occlusive crises happening. So as we know, the stickiness happens because the p-selectin is secreted, which attracts the white blood cells, the platelets, and the red blood cells, including the red blood cells with sickle hemoglobin in it. So it starts to get nice and sticky, and things start to clump and stick together. In terms of clustering, after a while, more and more cells decide to join the party, and this blockage is starting to build up and happen. And then finally, the blockage occurs, and that's because all the cells come together, have a little party, and decide they don't want to let the blood through, and also not let oxygenation happen, leading to ischemic injury and some damage to the endothelial walls of the blood vessels. And this can happen anywhere in the body, as we know. So this pain could be widespread, it could be quite localized, and that is where the crisis is happening at that point. I'm not sure I'm terribly fond of the word crises. I prefer sickle cell pain because this sickling happens all the time and can last days, can last weeks. You could finish one and then go straight into another one. And our patients, it doesn't necessarily mean they have to come in the hospital with the pain. They can manage at home. But if they come in the hospital, we sort of call it crises. So just a little picture for those of you who like a little bit of an infographic for it. So as you can see at the top there, the blockages are happening, leading to ischemic injury and lack of blood flow, which causes intense pain for the user. Obviously, I can't comment on what that pain's like. I don't have sickle cell, but I can only go by what our service users are saying, and that the pain is horrific, usually. The worst pain they've ever felt. And again, nice brief little sciencey diagram for you guys. As you can see at the top left, it's starting off with oxygenated red blood cell, and when the hemoglobin gives off the oxygen, the hemoglobin tends to polymerize and cause those long, straight, thin rods, which morph the shape of the red blood cell, causing it to cause like that C sickle shape. And due to that, that causes, oops, sorry, I'm just letting someone in. And due to that, it clumps up the blood vessels and attracts all the other cells, which causes damage, causes infarction, hypoxic damage, various different bits, as I'm sure you guys all know. So quickly, just moving on to the NICE guidelines. We have a NICE guideline produced in 2012 saying sickle cell acute painful episode, management of an acute painful sickle cell episode in hospital. So we need to do this really patient-centered. We need to treat an acute painful sickle cell episode as a medical emergency. I personally feel like we should treat it as if it's the sepsis golden hour, because I remember being a nurse on the wards, and that always got you going and ready to go. And throughout an acute painful sickle cell episode, regardless of the patient and or their carer is an expert in their condition, so we need to listen to their views, okay? Obviously, we need to work with the carers as well, or their friend or family member. And so we can get consent in order to be able to liaise with them. But as we all know, they've lived with this condition for years. They know what drugs work, what sort of doses they normally have. This is especially valuable in negotiating the patient key record and also if they're a patient from out of area. So guys, what are the recommendations for analgesia? How quickly should they be receiving analgesia when they go into hospital? Someone wants to shout out?
Ideally within 30 minutes, but it depends on what analgesia they've taken prior to coming to the hospital.
Yeah, perfect. Thank you, Karen. So yeah, we've got to take into account what they've already had, because some of our patients have opiates at home already, or if they come in via an ambulance crew, then we need to think, what has the ambulance given, which of course will be all over in the handover anyway, for when they transfer them in. However, if they've come straight from home, say they've got a taxi or whatever, it needs to be within 30 minutes of arrival and check-in and being navigated, which we aren't quite hitting. This is like data we're collecting from all over A&Es all over, and the percentage you're actually hitting is about 15%.
To this thing.
Sorry guys, can you mute if you're not got a question? Just getting some feedback, thank you. So yeah, within 30 minutes of arrival, our data shows that we're doing quite poorly across London for this, which leads to increased pain, agitation. Our families be getting upset and angry, understandably, because they're in so much pain. So as I said, offer analgesia within 30 minutes of presentation, and pain should be under control within 2 hours, ideally. And with our patients, they sometimes need quite a high dose of opiates, so we need to encourage our staff not to be too worried about giving that prescribed dose. I remember doing it myself when I first came to London for nursing and thinking like, I'm going to really cause a respiratory arrest here, but our patients tend to tolerate it. Obviously, we need to be able to assess whether they're opiate naive, whether they've had it before, see what their patient key record says, and go from there. Karen, do you want to ask? See, you've got hands up.
Yeah, I hope that this isn't a stupid question, but it's something that I've just never thought of before. Have you got any feel? Can you give, because there's quite a lot of people on the call from North Mid that don't routinely work with sickle patients, a feel for what opiates other patients would have? So I don't know, if you were if you'd broken your leg, fractured your hip, what sort of opiates would somebody like that have? Just so that we've got a context to put it in.
Of course. So from my background, obviously I'm pediatric trained, so if we had a child or a teenager come in with a fracture, say they've fractured their radius and ulna, so fractured their arm, we would give intranasal diamorphine if we have it, but we all know our stock of diamorphine is critically low. If they are, say it's an adult, I've seen them give some ketamine before as well. Someone else trying to get in. But in terms of other procedures, normally they'll give a tiny dose of Oromorph to try pain relief. So I've seen people only get like 2.5 milligrams of morphine because they're really careful, because they're all opiate naive. Sometimes our chronic pain patients, for example, I used to do a lot of medically unexplained symptoms type nursing. So quite a few of those patients will have oxycodone, and that works quite well. But for us, it's usually morphine is the first line, alongside some oxycodone for some patients.
And I've heard the term opiate naive, obviously, a lot. How can you check that when a patient's coming in? Would that be on their sickle protocol? So obviously, if it is an opiate, presumably they're not opiate naive. Would you have to ask the parents, the patient?
So generally we would ask in our initial assessment, like we have access to patient key records, even if they're not our patient. If they've got one, we can easily get a hold of it. So if they have a patient key record is because they have been using opiates before, and we know what doses we need to give and which drug. But in terms of, say, for some random reason we can't get hold of it, then we'll ask them if they've had it before, and we tend to take their word for it. But we might err on the side of caution, and we'll just use our Meadle. I don't know if you guys have that at North Mid. It's like an algorithm for what to do with a patient that comes in.
I don't think so. I'd be very interested in seeing it if you're allowed to share it.
Yeah, I mean, we've just revised it, and it should be going on our intranet shortly once it's gone through all the governance meetings. But it's like a simple flow sheet which says, are they in pain? Is it moderate? Is it severe? Is it going to be, are they managed, what have they had at home? And it just takes you through like yes, no sort of things.
Gosh, yeah, I'd be really keen on having a look at that if I can.
Yeah, of course, I'll send it over to you. I've got it in my inbox.
Thank you. I'm going to shut up now.
No, you're fine. But generally speaking, if we don't know the patient, then we give some morphine. But I've got an example of a PKR shortly. So again, analgesia choices. We need to take into account what the analgesia the patient is taking before presentation. So as I said before, some of our patients have opioids at home who maybe decide to take some before they come in. Who knows what they've taken? If they've had codeine at home, again, because we can give that out for mild, moderate pain. I'll never forget the one time, it's not sickle related, but I had one lad who fractured his arm, and he went outside to meet his friend for a bit of fresh air, and then he came back up and asked for pain relief, and I gave him some codeine because that was prescribed, and he failed to tell me that his friend gave him codeine mixed with Sprite outside, and quite a lot of it, because apparently that's a new high. So there's me panicking as a junior nurse, like, have I caused opiate toxicity there? But thankfully he was fine and got a good telling off. Ensure that the drug dose and administration route are suitable for the severity of the pain and the age. So, for example, some of our patients, as we know, have subcut analgesias, have parentals. Some of them just have orals. So just things like Oromorph. Offer a bolus dose of a stronger opioid by a suitable administration route for managing acute, painful sickle cell episodes. Okay, so now we're going to look at how to reassess and the ongoing management. So we need to do our observation and pain score every 30 minutes until satisfactory pain relief has been achieved. We need to be constantly reassessing. And I know this is really difficult in busy ward life, busy A&E life. You've got all these patients. However, we can't give a dose of painkillers and think that's it. They're done for, say, 4 hours so they can have their next dose. With things like acute painful crises and sickle, we need to be on it and give more and more if we need to, and then reassess and think, do we need to move on to another kind of pain relief? Do we need to give more? Do we need to switch to a PCA? After pain relief has been achieved and it's manageable, we need to be reassessing the pain every 4 hours unless the patient dictates that their pain is increasing. We need to use an age-appropriate pain scoring tool. So in adults, quite commonly, they'll use the 1 to 10 or 0 to 10 pain score. Some hospitals like UCLH, we do 0 to 4, 4 being the worst pain ever, 0 being nothing. But for the younger patients, we need to be mindful of what their developmental age is and how they can interpret it. So we have the smiley faces, obviously not the most accurate, but it's what we can do for children because they understand emotion. We can also use different coloured symbols for little tiny ones. We can use the FLAC score where we look at how they're reacting to stimuli. But generally in adults and teenagers, the number method is pretty good. If severe pain on reassessment, we need to offer a second bolus dose of strong opioids, okay? And consider PCA, as I said, if repeated boluses are needed within 2 hours of presentation. So all these different little medications, if we are giving opioids to someone and they're going to have a fair few doses of it, what extra medicines should be prescribed alongside it as like supportive medications. I've given you one there. Laxative should be prescribed, but does anyone want to say what else should be prescribed?
Antiemetic.
Yeah, perfect. There's one other for oral and subcut routes. I don't know if any, sorry, say that again.
Is it antihistamine? Like Piriton?
Yeah. So things like Piriton, so like anti-itchy stuff, antipyretics. So quite often, because of the doses that we're giving and the frequency that we can be giving out, our patients are, the pain's okay, but they're so itchy, which we know is a side effect of morphine, tends to start on the nose and then can spread anywhere. So we need to make sure our patients are comfortable, because if they scratch themselves, they're just going to cause more damage. So antiemetics, because some people feel quite nauseous with opioids. We typically use ondansetron, then we can move on to the second line, cyclizine. However, cyclizine we do not give IV. At my trust anyway. I think that's quite common guidelines around the country. And antipyretics, as I said, so the anti-itchy stuff. And we need to monitor the patients closely, take strong opioids for adverse reactions, as I said, and perform a clinical assessment, including sedation scores. So using your AVPU and documenting that clearly, because if we're not doing that and we don't understand and recognize that the patient's getting a bit knocked off and a bit sedated, this could quickly spiral into respiratory arrest. So in terms of monitoring, we need to do every hour for the first 6 hours. At least every 4 hours thereafter. Let's quickly fly through the standards now. So again, it simply states that the first dose of appropriately potent analgesics must be administered within 30 minutes of presentation to a clinical area and should include time spent in triage. The on-call hematologist should be informed. The regular assessment and monitoring of pain, so we can administer more if needed, alongside vital signs. If the patient's discharged, a discharge letter should be sent within 10 days to the GP, so they're aware. Some of our patients go home on a weaning plan because we provide medications on discharge. So we can understand, we can update the GP saying you might need to supply some. This is the plan we're sending them home with. Can you monitor it in the community? If the patient is discharged but reattends within 48 hours, that needs to be reported as a failed discharge. And we need to get data for that, at least annually. Hospital-specific stuff what we could do for pain is patient key records. We can know what their background analgesia is, so we know what they're actually having at home, what they could have taken before they came in. And it also tells us the details of hospital pain management plans, so what they get when they come into A&E, what they can have on the ward, how long they might get parenteral analgesics for before we switch to orals, whether they have had a PCA before and we're happy for them to have one. Subcut PCAs, again, different trusts do different things. So some we can do IV PCAs, sometimes we do subcuts. We prefer subcuts for our group of patients just because of the damaged blood vessels. We don't want to scar up any more veins and cause any more damage than we need to. I don't know, you guys, what you use where you do. If you're mainly North Mid, I know we're going to be doing subcuts, aren't we? When we roll it out.
Yep.
Yes.
Yeah. And it's sometimes very ward specific. Not every ward has training to be able to do a PCA. Normally it's quite common in surgical wards because post-surgery, quite a few patients have PCAs or on gastro wards, for example. But for our patients who have quite high doses and might need high concentration PCAs, the best place for them to be is on a hematology ward. So we can monitor appropriately and escalate if needed. So like I say, location of patient, are they in the most appropriate ward? So for example, at UCLH, some of our outliers end up staying in what we call it SDEC, or might pop to AMU. And for that reason, we'll try to move them up to hematology ward as soon as possible because they won't be able to manage and set up a PCA down there. And if our patient needs it, we need to sort it out quickly. So just looking at the moderate pain, what we advise for that. Follow the WHO pain ladder, which is down here, as you can see that picture. So step one is just paracetamol or NSAIDs, so things like ibuprofen. we can then step up to adding in a weak opioid for mild to moderate pain. So we'll add in some codeine, dihydrocodeine, or tramadol. That's the level what we call moderate pain. Okay, that's amenable to codeine, dihydrocodeine. But if we're moving on to step 3, we classify that as severe pain. So that's when we treat it with morphine, fentanyl. It says methadone there and oxycodone, but this picture I've given you isn't specific to sickle or red cell conditions. It's just the WHO ladder. So at step 3 would be using morphine or oxycodone usually. So for severe pain, unless the patient has a PKR, so patient key record, suggesting otherwise, morphine is the drug of choice. We can give subcut morphine 0.15 milligrams per kilogram hourly or certain intervals. Sometimes it's hourly, sometimes it's every 90 minutes, sometimes it's 2 hourly, depending on what the need is. We can also give oral morphine, which may be preferable, especially if they just transition from pediatrics, because pediatrics and adolescents, they don't typically always get parentals. They're not used to having subcuts, they're not used to having IM injections. So to surprise them, like, oh, we're going to poke you with this every hour. It doesn't always go down well, even if you have an insufflon in. So we are encouraging our patients to move from parental analgesias to oral analgesias once pain is settled, like to do it as soon as possible. We will titrate the doses, so we're giving the same amount orally as we would subcut, which we explain to the patients that it's the same drug, it's the same dose, it should be working just as well, but for some reason there's that thought that it's not going to work quite as well. So this transitionary period can take a little bit of time. Talking the oral doses now, the oral drug of choice is immediate release morphine sulfate. I'm taking this from the guidelines we have here at UCLH. Obviously, every trust is a little bit different, but we're trying to standardize everything as well. So if the weight is below 50 kilos, we can give 20 milligrams at presentation time. And as you can see here, 20 milligrams 1 hour after first dose, 20 milligrams 3 hours after first dose, and 20 milligrams every 3 hours. This could be Oromorph, it could be things like Sevrodol, whichever brand or make you have in your hospital. If the weight's above 50 kilograms, above or equal to, we can give 25 milligrams as per the above timings. If morphine sulfate is used after pain has settled with parental analgesia, if weight is greater than or equal to 50 kilograms, we can give 25 milligrams free hourly. If weight's below 50, we can give 20 milligrams free hourly, as I've already mentioned. I'm going to quickly talk to you guys about PCA, because not every trust uses them, not everyone is used to them or trained on them. So this is the PCA pump that we have at UCLH, and also the North Middlesex have got in. It's called the CAD Solis. It's also used for ambulatory chemotherapy, so things like cytarabine, cyclophosphamide, and bits and pieces. However, we use it for PCA, for patient-controlled analgesia, using morphine or oxycodone or fentanyl. So as you can see, R1, it tells us there what the continuous rate is. So if we're having a background, we can program in, so they've got a constant trickle. In terms of the bolus, we can give a certain amount every 5 minutes, depending on the lockout time. We do 5 minutes or 10 minutes or 15 minutes. And we can play with this as we're trying to wean off a patient or lower the doses. And the pump will also tell us how many doses that the patient's pushed the button for and how many times the doses have been given, because we get records of that. So briefly, if the pain persists despite repeated bolus doses of strong analgesics, then patient-controlled analgesia should be considered. PCA has been shown to be effective in achieving pain relief for smaller total doses of opioid analgesics compared to continuous infusion, thereby having the potential for fewer adverse effects. Further repeated bolus opioid doses do not achieve smooth and sustained analgesic effect. PCA should therefore be considered for analgesia in patients who are admitted into hospital with painful crises. So we do have some patients in our patient key records where we said that they can have a PCA, and we've given the doses that we normally use. Anything different to those doses need to be discussed with the senior. As I said, we can add a continuous background infusion, which is independent of patient request for analgesia. So the technique enables pain management to be tailored to patient need, providing the patient with control and minimizing delay in administration of analgesia. So for example, we often use like a 1 milligram background with a 1 milligram bolus for those who are new to a PCA. If we have say we have like a high intensity user coming in because they're in frequent pain, we might have specially adapted prescriptions. So the prescribing, the PCA should be initiated under supervision of a red cell consultant. Again, this is UCLH policy. It will likely be similar elsewhere. Prescribers should prescribe in line with the TRCN policy and guidelines, so we know whether pharmacy dispenses a pre-made morphine bags for you, pre-made oxycodone, fentanyl, how it's stored, so it's stored in the CD cupboard, as we know, who can sign it out, and how you dispose of it. Prescribers should ensure the correct drug, route, concentration, and dose is prescribed using the patient's key records stored in medical records. Prescribers should review PCAs daily or more frequently if clinically indicated. So depending on how quickly we are trying to wean someone off of the PCA, we might review it twice a day, sometimes every 6 hours, where we say, okay, let's drop it by 0.5 milligram. We'll maybe take away the background before we take away the bolus, but it's in constant reassessment. And the PCA should be prescribed by the red cell team in the daytime ward round. That's the safest way we can do it. However, we can do it out of hours, but under special conditions. So like I said, out of hours, but only under special circumstances. So that usually means we're waking up the consultant out of hours in order to say, can we start one? And depending on your trust policy about who sets it up and their availability. So for example, we can set, the hematology trained nurses are trained at a higher level, so they're able to program pumps and set them up. However, elsewhere in the hospital, it's down to the on-call anaesthetist who might be intubating someone in A&E, so there might be a delay, there might be some issues. Subcutaneous is preferred route, as we know, due to poor venous access. Doses greater than 15 mils, doses that might deliver more than 15 mils an hour can be very painful. So we need to make sure that we're getting the correct bag. So some of our bags can be made up to be high concentration, so it's delivering less. So it's less volume going in and we're not forcing as much fluid to go in somewhere that shouldn't be there. So when we are ordering this, we need to be very, very careful about which bag we use. Normally they have the big old bright sticker on it saying high concentration, but we need to make triply sure that you're using the right bag, because you might end up overdosing someone, you might end up underdosing someone. And there's a little brief talk about how much we normally do. So that, say for morphine sulfate, which is the most common, it's usually 100 milligrams and 100 mils. That's how we dispense it. 1,000 milligrams in 100 mil sodium chloride is the high concentration one. So as you can see, it's 10 times the strength in the same fluid. So please, please, please be careful. Again, supportives, prescriptions. If we're using a PCA, what's the other big drug that we should have on here alongside the other ones we talked about earlier? Give a little. Oh, someone said it.
Naloxone.
Yes, thank you very much. So yeah, naloxone is the reversal for opiate toxicity. So it always needs to be prescribed alongside oxygen. Okay, so if it's pretty much when they're prescribing a PCA, please ensure that they prescribe that as well, because you're kind of stuck if you don't have that. So as I said before, laxatives, simple analgesia, antiemetics, antihistamines, naloxone. And I don't know if anyone's ever given naloxone, but it's nothing like in that film Pulp Fiction. You know, it just helps them breathe more and regulate their respiratory systems. Generally speaking, we give naloxone if their respiratory rate is less than 8 breaths a minute. And that's when we'll do a bit of reversal and reassess the dosages that we have. Oxygen as well, because we know oxygen for our patients can offer pain relief as well as maintain their oxygen saturations. But again, we need to be mindful that if we're doing their vital signs, we need to do their oxygen saturations in air, not on oxygen. So the monitoring of a PCA. Once it's first set up, we need to monitor every 15 minutes for the first hour. And then for the next 4 hours, every 30 minutes. For the remainder of the first 24 hours, every hour. And then if they're stable after 24 hours, we could do it every 2 hours. That's just the basic things like respiratory rate and pain score and sedation. We need to do the full set of vital signs every 4 hours, and more if you're worried. I just want to talk to you quickly about this case study that happened. So unfortunately, a patient died after being on a PCA. So his name is Tyrone Airy. He's 46-year-old. He attended Norfolk Park after becoming unwell with sickle cell crises, so he was in a lot of pain. And it showed that the staff did not follow the required monitoring and escalation for pain scores, sedation scores, and monitoring of blood oxygen saturation or air, and did not take place at intervals stated in local trust guidelines and national guidelines for acute pain associated with sickle cell disease. So he was popped on a PCA, but he wasn't being monitored properly, and unfortunately had a respiratory arrest because he was over-sedated, and people weren't noting down sedation scores or escalating appropriately. That statement I just gave you is from the coroner's report. The coroner ruled that his death was contributed to by neglect. So we need to be really mindful of our patients. Okay, they've had opioids in the past, but they might not have had it subcut, they might not have had it IV. And we need to ensure that we're monitoring them super closely. I didn't mean to scare anyone, but we need to avoid this happening again because this is avoidable. Very briefly, I want to show you an example of a patient key record. So it's a personalized record and degree plan on presentation in the hospital. I've lifted one from one of our records, but it's all anonymized, obviously. So on our PKRs, we have the baseline oxygen saturation, so we know what we're looking at when they come in, so we know what could trigger an acute chest syndrome, when we should be worried, and what we expect them to be able to do. So pain management, we separate it. We talk about acute, so A&E and daycare unit. So for example, this patient has background oxycodone modified release, which is 50 milligrams BD. They have that at home. And then we continue that in hospital. We will also give IV/PO paracetamol 1 gram QDS as normal. We'll then give PRN oxycodone 20 milligrams subcuts every 90 minutes for the first 24 to 48 hours with the aim to stretch it to every 2 hours. And if that's not quite working and we need to keep giving lots, we might switch to an oxycodone PCA with 3 milligram lockout, 3 milligram bolus, so just a bolus, no background, with a lockout period of 10 minutes. So he can push it, but it will only give a dose every 10 minutes. And we aim to move to oral immediate release oxycodone as per what the outpatient doses were as soon as possible, especially within 2 days of a red cell exchange being carried out. Not every patient has a red cell exchange, obviously, but sometimes they need one. So that's why it was added onto that for him, for that patient. If the patient is new to the hospital, so say he's not from our trust, and quite handily, there are contacts for North Central London where you can access their patient key record if they have one. If not, you need to go back to what we talked about before with the initial doses of morphine. So I'm just going to briefly touch on chronic pain just to end up. So chronic pain is usually defined as persistent pain lasting for more than 3 months. In patients with sickle cell disease, this needs to be distinguished from a long-lasting or repetitive acute pain crisis. So as I was saying before, these crises can happen repeatedly, like you just finish one and the next day go into another one. It's not necessarily chronic pain, it's just frequent acute pain. Also, we know the complications that our patients have. So they might have some avascular necrosis. So of course it's going to cause pain because we've got a joint that's necrosing. So we need to be able to treat that cause as well, because that's the source of the chronic pain. So a nice little diagram I found for you. So called chronic pain cycles. So there's pain, anxiety that pain is signaling tissue damage and harm. Brain becomes more focused on the problem, which leads to changes taking place in the nervous system, which increases the pain, and more anxiety and less movement, which again causes more change to the nervous system. So it's just going around in a vicious circle. So the standards for chronic pain management is patients should be asked about whether they experience chronic pain as part of their annual review. So annual, as we know, means yearly, so we'll bring it up. Use of opioids should be regularly reviewed at clinic visits, including at annual review. So for those patients who have opioids at home, we need to review it so we can weigh up the risks and benefits. An underlying cause of chronic pain should be sought and treated if appropriate. Patients with complex pain should be referred. Patients with complex pain needs should be referred to a multidisciplinary chronic pain team or complex pain team with experience of sickle cell disease, offering both pharmacological and non-pharmacological interventions. So we go with a massive MDT approach where we involve psychologists, we involve physiotherapists and various other allied health professionals who can help alongside the medicines that we're giving. And that seems to work quite well with our patients. So chronic pain in patients with sickle cell disease may result from obvious tissue damage, such as avascular necrosis or a joint or an ongoing leg ulcer, which we know is quite common. In these situations, treatment of the underlying cause is paramount. In other situations, the pathological basis is less clear, but the pain may be due to slow to resolve acute painful episodes or chronic pain syndromes associated with previous tissue injury, central sensitization, and neuropathic pain. So central sensitization is a result of excessive nociceptive signals acting on the central nervous system, causing changes of the brain and spinal cord. And the consequences is continuous and increased pain sensitivities. Central sensitization has been described in many chronic pain syndromes and in sickle cell disease. There is some evidence that patients with higher levels of central sensitization have more pain and experience more vaso-occlusive crises. There's a lot of S's in that for someone who has a little bit of a lisp. So I do apologise for messing up my words there. So yeah, these painful episodes and reaction to painful stimuli can then trigger another vaso-occlusive crisis. So they've got a chronic pain and acute pain. So it's a bit of a minefield to try and treat. But the management is we do MDT approach between clinicians, psychologists, and other allied health professionals, regular reviews in clinics, investigations into other causes. So we don't just dismiss it as being chronic pain. We need to think, is there something else that's happening? Is there an infarction happening? Is there necrosis happening somewhere? We need to treat underlying issues. So if they have a leg ulcer or avascular necrosis, we need to get in touch with the relevant teams, sort out treatment for that, and hopefully that will help resolve and settle things down. We need to individualize care plans, homeopioids if required, and they need to be regularly reviewed and risks weighed up. Neuropathic pain medications if indicated, so things like duloxetine or amitriptyline might be used in order to help with neuropathic chronic pain. And we need to help the patient help themselves, so we need to help some self-management techniques, so things like breathing exercises, yoga, distraction techniques, things like that. Okay, I've done a lot of talking, but we've come to the end. Does anyone else have any questions for me? Awesome, guys. Well, if you joined late and you didn't see the message, please can you put your name, your job title and where you work in the chat. I'm happy to be contacted about anything regarding pain management in sickle cell. You can email the network email address and I will receive it. Okay, but I hope you guys found that useful and enjoy the rest of your day.